Assisted reproductive technology refers to a art and science of getting gametes together, may be done by artificial or partial artificial means, may or may not involving the third party. IVF, example IVF parents own gametes, that is artificial reproductive technology. Third party reproduction, use of oocyte donation, sperm donation, embryo donation, or uterus surrogate motherhood that have been provided by a third person to enable an infertile individual or couple intended parent to become parents, while the donors may be known or anonymous to the intended recipients depending upon the process of the recruitment. The surrogates are usually known to the intended parents. The guidelines for ART in India have been laid down by ICMR, National Guidelines for Accreditation and Supervision and Regulation of Artificial Reproductive Technology Clinics in India, 2005, abbreviated 2000. No punishment have been mentioned. Not following guidelines may at most call for an action by Medical Council of India or a state medical council. Techniques: artificial insemination. AI is an artificial introduction of sperm into the reproductive tract of a female to produce pregnancy. Types: artificial insemination homologous, husband, semen of husband is used. Artificial insemination donor, semen of some persons other than husband is used. Artificial insemination homologous and donor, pooled semen is used, by which a semen of both husband and donor are mixed. Medical aspect: donor advised not to ejaculate for 2 to 3 days before providing the sample in order to increases the sperm count. Tested for HIV, hepatitis B, semen cannot be taken if a donor suffering from this disease. Collection of semen through masturbation, use of an electric stimulator, use of a special condom to collect semen during intercourse. Quarantine: the sperm is quarantined for a period of 6 months. Donor retested prior to artificial insemination. Woman's menstrual cycle is closely observed by tracking basal body temperature and changes in vaginal mucus or using ovulation kits, ultrasound or blood test. The time of maximum fertility coincides with that date of ovulation. Ovum can survive for a maximum up to 24 hours without fertilization after it leaves the ovary. Similarly, spermatova survive for a maximum of 24 within the female genital tract. They take an average of 6 to 24 hours traveling from vagina to tubes because of uncertainty of ovulation. Difference between this artificial insemination homologous and artificial insemination donor. Artificial insemination homologous or husband donor is husband indication as in consent needed from both husband and wife, a precondition, and donor carrying and medical test. Sperm count should be normal. Other protein test. Disclosure of identity known to each other. Outcome of artificial insemination: husband knows confidentiality not between donor and recipient, but confidentiality maintained from general public. Doctors or may deliver the child who conducted artificial insemination. Legal issue. Then artificial insemination donor, person other than a husband but not a relative, as in text, needed from husband and wife as well as donor and his wife. Donor should have his own child. Must be less than 45, should be of same race as husband, should closely resemble husband in physique. Sperm count should be normal. Other tests to exclude diseases like diabetes, endocrine dysfunction, epilepsy, hereditary and familial disorders, psychiatric disturbances, RH incompatibility, tuberculosis, transmissible infection, HIV, AIDS, hepatitis B, etc. Donor and recipient must not know each other. Donor must not know. Maintained between donor and recipient as well as from general public. Doctor conducting artificial insemination should avoid delivering the child as it would lead to disclosing the identity of father in birth record. Indication for artificial insemination homologous: male factors, husband has an erectile dysfunction, Husband has a physical anomaly making he unable to deposit semen naturally: elephantiasis, epispadiasis, hypospadiasis, hydrocele, penile and scrotal tumor, retrograde ejaculation. Husband is dead and his semen was harvested after death. Posthumous assisted reproduction. Female fractures, cervical stenosis. Persistent cervicitis, scant or unreceptive mucus. Postmortem sperm retrieval was first reported in 1918 by Cappy Rothman in a case involving 30-year-old man who became brain dead following a motor vehicle accident, whose family requested sperm preservation with the introduction of intracytoplasmic sperm injection in 1992. Many widows began requesting for harvesting of seminal fluid of their dead husband for artificial insemination of homologous or artificial insemination husband. On May 21, 1993, in Orlando, Emanuela Maraska became the first person in the history to donate sperm posthumously for artificial insemination. Maraska, 22-year-old old widow, Pamela Massa, married to him only 60 days earlier, wanted to be impregnated by her husband's sperm. Mark Jurata, a reproductive endocrinologist, extracted epidermis to harvest sperm. For artificial insemination, donor: husband is sterile, husband suffers from hereditary diseases, wife is allergic or isoimmunized to husband's sperm, husband suffering from HIV or hepatitis B, woman is unmarried or a widow, lesbian couples RH incompatibility. For artificial insemination, artificial insemination, husband has oligospermia by mixing semen with that of donor. Sperm count is brought to normal with a possibility that husband's sperm would fertilize over. Precaution: consent of donor, recipient and their spouse is essential, as both donor and recipient identifiers are shielded from each other. Physician is the only link between the two. It should be specifically stated that the physician has full discretion to choose the best possible donor. Essential requisition of donor: blood group: no RH incompatibility, should have same blood group as that of husband. Family should have completed their own family. Health should be physical and mentally healthy. No family hereditary diseases, sexually transmitted disease, HIV, etc. Chromosomal study should be done on him for possible genetic defect. Physical characteristic: race should match that of the husband and recipient as close as possible. Relation with the couple should have no relation to either the spouse or single donors. Semen should not be used to produce more than 10 children. More children in different families from same donor would ultimately increase the possibility of consanguineous marriages. Couple should be physiologically fit and emotionally stable. Witness must be present at the time of insemination. Delivery should not be done by the physician who performed artificial insemination. This avoids the necessity of either falsifying the records of or disclosing true paternity in the record. Thank you.